So our goal today is twofold. One, just to celebrate National Rural Health Day. Two is to get a chance to listen to Senator, or hear from Senator Wyden about what's going on in D.C. At this point, and with the elections over, where he might see healthcare going, how that might impact us from a rural perspective and just from a healthcare perspective in general. We are going to have time built in for questions and answers, so please think about what you may want to ask Senator Wyden when he comes on. It can be anything specific to what you're going to study, to the bigger issues that are facing Oregon, et cetera. And then when he's finished around 12:30 or so, we'll have Dr. Law from Astoria come in and just give us a little bit about why he is a rural provider, the pluses and minuses and challenges that he's faced. And then we'll close out closer to 1 o'clock with just a reminder of the work that Bill and Stacy do for you all that are going to be looking for jobs and provider incentives and that type of stuff. So with that, we will just hang on for a few until the senator arrives. We hope that we may be able to make this more of a regular feature where we can bring in the senators from D.C. It's a lot easier for them to sit in one location in their office in D.C. and hit us at all these campuses than it is trying to come back here and fly around and get to everybody's location. So with that, can I open it up to any questions that folks may have that they might want to ask us at the Office of Rural Health, either about National Rural Health Day or some of the things that are going on with healthcare here in Oregon? Yeah, sounds false. Again, for those that are just joining, we're waiting on the senator to join us. Joe, I can see your lips moving, but I can't hear what you're saying.
That was on purpose.
Oh, okay. While we wait, Bill, do you want to jump up and talk a little bit, and then you and Joe can go back and forth and talk quickly about the incentive programs? For those that don't know, Bill is our provider incentive program manager here at the Office of Rural Health. And Joe, raise your hand, Joe, is with the Oregon Health Authority and works with Bill on the various provider incentive programs. So I'll let them do a quick spiel before we go on. Oh, yeah, go ahead and give, because people will, as they sign on.
Oh, will pop up. Gotcha. Thank you, Buck. Yes, my name is Bill Funder. For those of you who don't know or didn't hear, I am the Incentives Program Manager for the Office of Rural Health. The Office of Rural Health administers provider incentive programs for the state of Oregon. We have both loan repayment programs and loan forgiveness programs, as well as a tax credit and malpractice insurance subsidy. Loan repayment programs are for providers currently working in the field or about to go work in the field, and it will pay, these programs that we have, will pay a portion of your student loan debt in exchange for a service obligation at a qualified site. Loan repayment, we have two different loan repayment programs. The first being the state loan repayment program. And without getting into too much details about awards and things like that, a state loan repayment site must be a nonprofit, offer discounts for patients at or below 200% of the poverty level, and also be located in a health professional shortage area. So we're talking about places like federally qualified health centers, a lot of rural health clinics. So there's both a lot of rural, some urban underserved sites. So if you're interested in serving in an FQHC, one of these kind of sites, contact me. I'd be happy to let you know if your site qualifies for that program. The Oregon Healthcare Provider Incentive Loan Repayment Program also requires that a site have a health professional shortage area score and be seeing the same amount of Medicaid and or Medicare patients that exist in the county in which the clinic is located. So it doesn't have that 200% federal poverty level thing. And the reason why there are different qualifications is to help different clinics and help different providers that are serving different underserved populations. So you can possibly qualify for one or possibly qualify for both, but you can only accept one. And if you come to us, we can help you determine, based on where you're practicing at, which site, which program best fit you as a provider based on the populations that you're seeing and the site that you are located at. Loan forgiveness programs are for students currently enrolled in school and are swallowing microphones. So currently enrolled in school and are in an approved world training track. If you are currently an AHEC scholar, that is an approved world training track. If you're at a Comp Northwest and are a rural scholar, AHEC scholar, or participating in Comp Northwest's world training track, that is considered an approved route for loan forgiveness. Through the Primary Care Loan Forgiveness Program, right now, applications are posted on the Office of Rural Health's website. So if you Google ORH or Office of Rural Health Oregon, our website will come up. Click on Provider Incentives, click on Loan Forgiveness, click on Primary Care Loan Forgiveness. You'll see that application. Again, it's online now. All of the qualifications there, I'm talking very fast, especially for this relatively early-ish, for me anyway, on a Thursday, so I'm not expecting you to retain all this, but just know, contact us, check out our website. But again, this PCLF application, it's very short, very simple. Fill it out. Applications are due by January 2nd. It offers up to $35,000 per obligation year. So as an AHEC scholar, you're likely, depending on your program, if you're an NP, PA kind of a situation, you're eligible for 1 year of funding at $35,000. Good thing about that is you only have a 1 year service obligation. So if you are awarded as a PA, NP, it's a 1-to-1, MDs, DOs, depending on where, if you're at.
Sorry to interrupt. Here in Lebanon, we cannot hear you.
I'm saying a whole lot of really interesting things. It was just
So,
bad.
sorry about that. We'll do some repeating. Get a little closer to the mic, which is right over there.
Does this help? Does this help?
Can you guys hear in Lebanon now? Woo. Is that wave a yes?
We can hear you down here.
In Lebanon, if you can hear me.
Everywhere else is hearing you.
Ooh, interesting.
Yeah.
Is there a number that we can have them call into or anything like that? Is there a?
Let me see if I can pull that up.
Perhaps if we held up a piece of paper. Please help.
How about now? Can the folks at Comp hear us? We can see you, but are you able to hear us? Sorry.
No, Joe. Comp Northwest.
Right, technology is only so good. That's why there's still some problems doing surgeries, telesurgeries.
But I say you should add something else to the data make it a very Kurt has got up and attacked me.
Well, when we solve this problem, one thing for the folks that are coming in on the phone, if you'll please be really careful when you're moving things around your phone and doing stuff, because we pick up and hear all of the paper crunching and all those kind of things. So it amplifies across the state. And also, while we work on that piece, those that have questions, when the senator arrives, if you're on your computer or trying to get a question in, if you would email them to ruralworkforce@ohsu.edu, that would be perfect, and then that way we can read those questions off as well. So if you are at your laptop and want to ask a question when the senator comes on, or if you know what question you want to ask when he gets here, please email it to ruralworkforce@ohsu.edu.
Thank you. And hopefully, the folks at Comp will know to call this in. If not, you all get to hear me twice. Talk very quickly and off the cuff because I wasn't expecting to be doing this so early. So yes, where was I? A PCLF, loan forgiveness, 1-for-1. PCLF requires that a provider, so if you're a student, you're in a rural training track, you can apply. And should you be awarded, you would be required to enter primary care upon graduation or completion of your residency if a residency applies. We have a whole list of what PCLF considers to be primary care up on our website. But again, if you have any questions at all, feel free to give us a ring if you have any questions. The PCLF requires not only that a provider work in primary care, but also a provider work at an approved practice site. Touch very briefly on what these loan repayment programs consider to be an approved practice site. But for PCLF specifically, you'd have to be working at a site that is rural, of course in primary care like we said, and the site would have to have a HPSA relevant to your profession, health professional shortage area, and also be seeing the same amount of Medicaid and or Medicaid patients that exist in the county in which the clinic is located. It sounds like a lot of stuff, but really a lot of these clinics in rural areas are seeing those Medicaid, Medicare percentages. If I had a thing here, I'd show a map of just how much of the state is rural and just how much of the state is covered by HPSAs. So there's actually a lot of qualifying sites out there. We do have an official designation of what is rural. Some of you who have heard me speak before know that there's a lot of misconception around, like, you know, my neighbors have chickens, therefore I am rural. No, you live in Gresham, that is not rural. I saw a goat on the Max. No, if you're by the Max, you're likely not in a rural area. Rural is 10 or more miles from a population centroid of 40,000 or more people, and that is by the crow flies and not by the street miles. So if you Google Maps and try to figure that out, which we have a lot of folks doing.
I apologize, but I got a pull rank. The senator's joined us, so we're going to turn it over to him. All right.
Let me say, call right now to.
Oh, what's that? See? Can Comp hear us okay now? Can the folks at Comp hear us?
Yeah, you're waving.
Okay, good.
Yes, we have you now.
All right, perfect. Thank you.
Okay. And we'll connect them now.
Does it work?
Push the magic button. There we go.
Good afternoon, Senator.
Is that you, Scott?
No, sorry, Scott is not here. It's just me, Bob Dimmick, Senator.
Oh, great, Bob. Glad you're there. And what would be your pleasure? What I'd like to do is make this a filibuster-free zone. Maybe offer just a couple of quick thoughts and then let students and practitioners talk about what they're interested in.
Absolutely, that sounds perfect. And so you know, Senator, we have folks that are here in Portland, in Coos Bay, in Klamath Falls, in Lebanon, and a few other spots throughout the state. So you get to cover the whole state with what you're talking about today.
Wonderful. And I think most of you know that today, nationwide, is National Rural Health Day. And I start with the proposition that you cannot have rural life without rural health care. And the fact is, in our state, most of the towns in our state are under 10,000 in population. And so, overwhelmingly, in Oregon, health care is a rural issue, is a quality of life issue, and in many instances, increasingly, the facilities that we do have, say community health centers, perhaps a small hospital, in a number of our rural communities, constitute the economic engine for those rural communities. It was why I led the fight. I'm the ranking Democrat on the Finance Committee. We've got jurisdiction over Medicaid. It's why I led the fight in this Congress to keep the far right from gutting, Medicaid. It would have been devastating to rural Oregon, number one. And number two, it would have not just hurt the health of our citizens, it would have done a lot of damage to the economic engine, which is the providers and the facilities and services that are offered. I'm just going to offer a couple of quick thoughts, and then I really do want to throw it open. I think all of you as practitioners have some extraordinary opportunities in front of you. When I graduated from law school and really wanted to make a difference, I had the good fortune to get involved working with senior citizens. I was co-director of the Oregon Gray Panthers. And I came to decide then that health care was the most important issue, because if you and your loved ones don't have their health, that was pretty much it. And Medicare then really had just two parts. If you broke your ankle, went to the hospital, that was part A. And if you really had a horrendous case of the flu, you went to the doctor, and that was part B, and that was Medicare. That is Medicare no longer. Today, Medicare is overwhelmingly about cancer and diabetes and heart disease and strokes and chronic pulmonary disease. And both political parties have largely missed what Medicare has become. So in this Congress, I was able to, with the help of Orrin Hatch, a conservative Republican from Utah, the chairman of our committee, I was able to pass, the President signed it into law, a bill that is going to start transforming Medicare, updating the Medicare guarantee to put the focus on chronic illness, the kinds of conditions that I just described, which look like they're going to consume about 80% of the Medicare dollar. And the Medicare program, of course, with 10,000 people turning 65 every day for years to come, will dominate government finances and much of American life. I believe this program really highlights some of the great opportunities all of you as students and practitioners are going to have in our state. First is, it is my plan as the author of this law to greatly expand the role of physician assistants and nurse practitioners and therapists, because I think there are a whole host of very valuable contributions the non-physician providers can make. Second, much of it will be driven by technology, telehealth. I know many of you have been interested in the whole issue of telestroke. When a patient has had a stroke and there's no neurologist nearby, we know, and you all as practitioners know, even a few minutes can make an enormous difference in terms of a patient's quality of life, whether they'll even survive. So we were able, in the chronic care bill that I described that became law, get a significant expansion of telehealth and reimbursement of those services for the first time under Medicare. So I'm very glad that Bob, who's a longtime, advocate of trying to redesign and expand services for folks in those nooks and crannies of Oregon that constitute our small rural communities. I'm so glad that he put together this program, because this is really what Oregon is all about. So let's use that as kind of an opening salvo. Softball questions will be especially welcome for this gathering, but let's talk about what all of you are interested in on Rural Health Day.
All right, thank you, sir. We want to start with questions. If folks that are in the rooms want to jump in and ask a question, and those that are on their sites can email us at ruralworkforce@ohsu.edu with your questions. So first questions. They're a shy group, Senator. How do you see the split of the House and the Senate this year impacting any changes to health care reform or to the Affordable Care Act, and what will happen to it?
My view is that health care was on the ballot in 2018. All across the country, there was a very significant portion of the advertising being devoted to matters like pre-existing health care conditions. I wrote the first and still only universal bipartisan coverage bill called the Healthy Americans Act in the Senate before President Obama took over, and it had a provision that provided airtight, loophole-free protection for those with pre-existing health conditions. You didn't have to go to bed at night worried that if you had asthma or diabetes that you could be wiped out and lose everything. And the fact that Donald Trump and his legal team were in federal court trying to unravel that was a very significant campaign issue. So I think health care is very much on the mind of voters. We saw that just a few days ago.
And one of the issues that came up during the election cycle was the single payer, and whether we would get a single payer system in the United States at some point or a vote on it. How do you see the direction of the single payer discussion going, and what will come out of that?
First of all, I believe that health care is a basic human right. I think you can talk about a whole host of issues surrounding this debate, but that's where I start. Now, the fact is we are spending enough money in America for all Americans to get good quality, affordable health care. This year, we'll spend about $3.5 trillion on health care in America. There are perhaps 320, 330 million people in America. You divide 330 million into 3.5 trillion, and you could send every family of four in America, if you wanted to do it. I'm not advocating this approach. You could send every family of four in America a check for $40,000 and say, here, buy health care. We're spending enough money. We're not spending it in the right places. We're giving short shrift to prevention. We're giving short shrift to non-physician providers. We're giving short shrift to basic ideas like using our negotiating power to hold down the costs of prescription medicine. So my sense is we're going to, apropos of Bob's point about single payer, we're going to spend some time having to even thrash through some of the definitions of what's being talked about. I'll give you an example. I have town meetings at home. I've had more than 915 of them. I don't give any speeches. I just kind of try to respond to questions and talk about what folks are interested in. So the other day at home, I was having a town meeting, and an Oregonian was standing up with a sign that said, single payer health care, Medicare for all, no private insurance. And I said, got your point. I think people in Oregon deserve to know that currently the fastest growing part of Medicare is the private insurance part. It's called Medicare Advantage. And Oregon has the second highest rate of participation in Medicare Advantage in the United States. So, Bob, there's going to be some questions with respect just to what is even being discussed here. Personally, as a ranking Democrat on the Finance Committee, with jurisdiction over Medicare and Medicaid and CHIP and over $1 trillion the government spends a year on health care. I think every American should have access to a type of Medicare option for their health care. And I would probably start by saying that the first step that ought to be made would be to allow people between 55 and 65 who are pre-Medicare, often very vulnerable, to be able to buy into the Medicare program on a sliding scale. That would be my sense of a sensible way to get started.
Great, thank you. One of the things you mentioned with Medicare about all the changes that may be coming and needed, Medicare helps pay for the GME program, which is so important to many of our providers and future providers. Do you see GME reform coming as part of the discussion with Medicare, and do you see a way in which we are able to expand the residency programs that we have in order to meet the needs of providers?
I would very much like to do that. And again, as with my comment with respect to the $3.5 trillion being spent, we're spending enough, we're just not spending it in the right places. I think that same thing is true with respect to medical education. It is not just a question of needing more providers. It is a maldistribution question. We have plenty of providers in the urban areas where families and spouses and the like often prefer to be for services, and it's harder to get those talented providers in the rural areas. We also need to get more non-physician, providers. We also need to address the question of financing medical education. I'm looking at some approaches where loan repayment and the like would be tied to the salaries that medical graduates, would be making when they are out in practice. So this is a hydra-headed challenge. Those are just some of the issues I'm looking at.
Yeah. Sure. So our group here, we're a research organization, and we work with and engage rural practices in research. And from your perspective, what forms of information or potential topics generated within a research context could better inform policymaking or legislation?
Well, I think the areas that would be most helpful to me would be for researchers to be able to show the gap between the cost effectiveness and healthcare effectiveness of what you're doing and the shortage of services and resources. In other words, the single best thing you can give a policymaker is hard data about what really works, what really makes a difference in a community, in the quality of life of an individual, and then say, well, if we had X, we had a telehealth facility or a community health center or something like this, this is what we could do, as opposed to trying to get someone on life flight, vast distances at vast expenses. So to me, the thing that is most valuable is to get hard, fresh evidence of what's really medically effective, cost effective, and then to say, here are the gaps in the services, and here's a more efficient way, for example, to deliver them. That would be particularly helpful.
Any other questions in here?
Good one, yeah. Hi, Senator. Kurt Still, Director of Oregon. My question really centers around the availability of clinical training sites for a lot of our students. There's a lot of competition across our state for preceptors and clinical training sites, and I know some states have started to develop incentive programs for practicing healthcare providers to take students. So I'm just wondering if there's any discussion on a national level to incentivize more practicing providers to become engaged in teaching the next generation of students, because there are a lot of barriers and challenges when faculty go out to engage future preceptors, and there's a lot of reasons why they don't want to take a student, and sometimes that is the rate limiting factor to increasing class sizes of a lot of these health professions we've been talking about.
I think it's extraordinarily important, issue. I'd be interested in your thoughts about what you'd be working on if you were in my shoes. In other words, I tell you, we have not had a lot of discussion about that in the Senate Finance Committee. If I'm understanding correctly, you're talking primarily now about a state program. You're not talking about a federal program. Is that right?
Well, is there potentially a way to...
Well, tell me if you would, how does the state program actually work that you might want to see pursued at the national level?
Yeah. The only one that I've heard of is in the state of Georgia, and preceptors who take students are actually given, I don't know if it's a tax incentive or a tax break or a tax reimbursement, I don't know exactly, but it's somehow tied to some sort of tax incentive, and I don't know if any other states have done it. I do know that Georgia has done it because they've been really, pressured by a lot of their health professions training programs to take more and more students and expand their programs, and there's just not enough sites to train students. So
what you're talking about then would be, say, a Providence, a Kaiser, somewhere like that. You would have one of their physicians take more trainees and would in some way be reimbursed for that. Is that what you're saying?
yeah, it wouldn't necessarily need to be within a Providence or a Kaiser. Maybe it's just you get a higher rate of reimbursement for your Medicare patients if you have a learner, whether it's a student or a resident in your clinic at that time. So it somehow incentivizes more providers to take students, because there is obviously a cost to taking a student. It does slow providers down a little bit, and that's one of the things that we hear is that they lose money because they're not able to see as many patients. Not quite as much of an issue at an academic health center as it is with the private physician.
I got my arms around around this. I think it's an interesting concept. So you would say, for purposes of medical education, there would be a higher level of Medicare reimbursement if they had in that clinic or in that program some learners who were having a chance to pick up the expertise they would need someday in practice.
Yes, as one idea.
Sounds too logical for the federal government. If you'll get Bob a name and an email, we'll follow up with you. I think it's very interesting.
Okay.
It took a while to lodge in my cranium what you were talking about. I like it a lot.
We're in Comp Northwest, if we can, really quick. We've got some medical students here, and we're wondering what, if you can speak to where things are at with federal student loans for graduate and professional students, because that's something we're very worried about, because we can't afford to go to school without things like Grad Plus and all of those loans.
Well, I'm very concerned about where we are with the student loans, and as you know, the Trump administration decided that they would, over my opposition as the senior guy on the tax committee, go out and borrow $1.5 trillion to give tax breaks to folks at the top, but have always had their eye on, cutting back on student loans and loan forgiveness and more opportunities for students to pay back if they went to an underserved area. I think it is this whole question of student loan repayment, not just for medical students, but generally, is going to be a titanic battle in 2019, because the Trump people have seen the deficits have gone through the stratosphere. The budget, nonpartisan budget people say it's primarily due to that poorly targeted tax cut, and now the Trump people are talking more about putting safety net and health care programs on the chopping block, and I intend to oppose it very strongly. And my version is we ought to be expanding loan forgiveness. We ought to be expanding programs that help medical students who go to an underserved area. We ought to tie repayment to what a student is making. I'd like to go 180 degrees the other way.
Thank you for that insight and for your support.
Any other questions at COM while you're on? All right, we had, any others in this room? We had a couple questions that are in
Here, we have a question really quick.
Okay.
So you mentioned that there's going to be more focus for Medicaid on chronic diseases, and what are the incentives?
Medicare.
Sorry, Medicare. For Medicare and chronic diseases, but what about preventative care? We don't see a lot of incentive for lifestyle management and things like that, and a lot of payment for those kinds of programs for patients.
Well, three cheers for you. One of the reasons that I wanted to make sure we got our foot in the door was that Medicare, being the biggest federal health program, is so often a kind of catalyst for other kinds of opportunities. And that is clear in terms of the Chronic Care Act under Medicare, is that if you're 65 years old and you need help for diabetes-related services, or you have cancer, or you've got some pulmonary questions, perhaps related to smoking, what it really tells you is we better be serious for the under 65 population as well in terms of prevention. Now, under the Affordable Care Act, which Donald Trump wants to repeal, we got some major changes which for the first time actually make it possible for companies to reward healthcare prevention. Now, I'm one who wants to modernize the employer-based system. 161 million people get their health care through their employer. And at a minimum, let's make sure that those 161 million people are at companies that are doing more in the preventive area so as to not have people arrive on Medicare at 65 with all of these conditions. Prior to the Affordable Care Act, the companies could do very little because there was a fear of litigation and were they discriminating against someone, this sort of thing. And now the companies have really been given a wide berth and a green light to be serious about healthcare prevention and offer incentives and rewards. And I think we're going to start seeing some benefit from that.
Thank you.
All right, we have time for one more question before the senator has to wrap up. Does anybody want to offer one more quick question that's here in the room? I do have one senator dealing with the issues of alternative payment models for Medicare and Medicaid and how those might be utilized in helping influence how we expand our GME sites or how we are able to help practices improve access by utilizing those alternative payment models.
Well, I'd be interested in what Bob's alternative payment models are behind the question. I thought that you all offered a very attractive idea that I had never heard of, a higher Medicare, payment for learners, in effect, being in clinics, and I'm very interested in this kind of area. Is the person who's asking the question in-house and could tell me a little bit about what alternative payment models they're interested in?
I can read the question. And what we're asking about specifically is the proposal that Corey Gardner from Colorado put forward that is called the Rural Alternative Payment Model, and it changes the structure of GME payments for any amount of time that residents are actually in rural areas, so that it gets away from the problem of the caps and urban training in the hospitals.
Senator, did we lose you? Joyce, are you there?
Yeah, I think it was too tough of a question.
Well, I have a specific staff member, Joyce, so we can follow up on that one. Let's see if we can pop him back in.
Should I try calling you, or is that going to work?
We are right at the end of his schedule, so whether we'll be able to get him back on or not, I don't know.
Okay, sounds good. He's going to give us a call here.
Oh, okay. Sorry about that, Senator.
Okay. What I got out of that was a questioner asking about an alternative payment model bill that seems to have been written by Senator Cory Gardner of Colorado. And if the person is there, let's see if they can amplify a little bit, and then I'll give you a kind of very quick summary.
So the proposal.
That question's
Actually, sorry. Can you hear me?
Yes.
Yeah.
All right, so the proposal suggests that we pay differently for GME time based on whether or not residents are in rural areas and what percentage of their time is in rural areas. So it's called the Rural Alternative Payment Model because it gives residency programs then the option of using the traditional method with the cap and the per resident amount, or having the option of billing that differently based on the amount of time the resident is spending in a rural area. And so instead of just a total increase in GME funding, which we don't necessarily want, it creates a separate pathway for moving and redistributing resident training out into rural areas.
Yeah, I think they're very interesting. That's why I touched on earlier the maldistribution issue. So I will follow up on the Gardner bill. I think that essentially reflects the same thing I was talking about. And let's do this. For those of you that have follow-up ideas, and Bob knows our Finance Committee team, Liz Jurinka, Jurinka, is the staff director for the Senate Finance Committee Democrats on health care. So any ideas you have, and Bob, if you can collect particularly emails and phones for the people who gave both of the ideas, Gardner, and then the question of higher Medicare payments for programs that use learners and the like. We'd very much like to be in contact with them. And let's use this discussion as a to-be-continued kind of program. I would be very interested in doing this, Bob, if you and Scott want to take this on a regular basis, several times a year, and have my Finance Committee folks meet with you. And look, I think I was told by the staff my job was to get on this program, and it's Rural Health Day in America, and I was supposed to just whip you all up into a frenzy of excitement about rural health care. I don't think I have to do it, because I think that the excitement level is plenty high right now. And I think, as is the case in a lot of areas, that's why I mentioned the fellow with the Medicare sign where he said, Medicare for all, no private insurance. And then I said, well, here in Oregon, the fastest growing part of the whole Medicare program happens to be something involving private insurance. What we need to do is exactly what you guys have been doing here, which is to kind of strip this down into facts and specifics and finding a kind of set of policies that transcend a lot of the traditional boxes that have dominated the healthcare debate. So I really appreciate you all doing it. I'd like to put this in the to-be-continued department. Bob will get me some names and addresses, and we'll figure out a way so if you're inclined, we could do something like this on a regular basis, and you could have regular discussions with our folks in the Finance Committee to get your ideas as well. So big thanks, good holiday to everybody, and really appreciate your giving me the time to get some of your input. Let's do it again.
Great. Thank you, Senator. We appreciate your time. I guess he's still with us as long as the picture's up. In fact, it's snowing in D.C. today, and some of the schools were closed. So if any of you have not been in D.C. During the winter time, I can tell you it's actually worse than Portland. So. Thank you, everybody, for your questions and your input. What I will do, Joyce, I'll follow up with your question. If other folks out there have got questions that they had but didn't get answered, please make sure you get them to us at the Rural Workforce at OHSU address. We'll bundle them all up and we'll get them together. And per the Senator's offer, we will try to continue to set this up with him, but also with his finance and committee staff. And for those that don't know why he was referring to committee staff versus his own staff, one of the advantages to being the ranking member of any committee on the House or the Senate side is you actually get a whole nother set of staff with a big budget and a whole set of offices. So if you go to his office today, you find all of the standard folks you would in any senatorial office. But over in the Senate Finance Committee, the Democrats and the Republicans all have their own staff. And he runs a lot of his work through the Finance Committee. So that's why he's referring to them versus his personal staff. That being said, we may be able to get a couple of them to do this as well. So that after the first of the year, it'd be a great chance to kind of keep thinking about the questions that you heard today, other questions that you have that we may be able to get some feedback on. And I think next year is going to be really interesting. So it could be a lot of fun. So is Dr. Law on? Yeah. There he is. Oh. Can you hear us, Dr. Law?
Yes, can you hear me?
Certainly can. And we went over with the senator, so we apologize. For the one thing that people may not know is a part of National Rural Health Day, there are a group of community stars that are put together, and there are people all across the country that are honored for the work that they do. And Oregon has 2 this year, one of which is Dr. Law. So congratulations, Dr. Law. If you go to our website or to our Facebook or Twitter, and we can send it out as well, there is a publication that comes out that has stories about all of the stars, and we'll get you that one for Dr. Law. Dr. Law, if you don't mind spending a few minutes telling us about why you find practicing in rural important and maybe one of the top joys and top challenges you've had?
Yes, well, first I wanted to express appreciation for Senator Wyden and the efforts that he's made to help rural health and boost specific provisions. And I guess we're going from the specific to the general talking with me. I'm not sure about being a star. I think I'm more like a offensive lineman, if only I was a little bit bigger. And I think it's really an honor to be asked to talk with you. It gave me a chance to reflect a little bit on what it is that we do every day. It's actually nice to be able to stop for a minute. Trying to corral a rural doctor on the move is not always easy, and I think we're actually sometimes I think we're endangered species. I think one of the biggest challenges about being in rural medicine is that it's climate change, and not the kind of climate change that you may be thinking, but the healthcare climate change. Neither of those, of course, are being helped a great deal by the current administration. I'm just going to put that little plug in there. But but Senator Wyden, in fact, is helping a great deal. And it's resources out here that are always a challenge. Having the ability to recruit means to bring people out to work with us means having the kind of resources that will support those folks, and also to retain them. I think education is really critical, all the way from kindergarten, when you start recruiting, to higher education, where most of you are now. Supporting all of those efforts is critical. I think, given that we labor in obscurity a lot of times out here, and it's not necessarily a glamour job, the question is, well, so why would we do it? I think there are three things that occurred to me thinking about this, and one is being part of a community. I think I've spent pretty much my whole life, my whole career, has been in working in a small town in rural medicine, and of course I grew up in Astoria, where I am now. It's my hometown, and I think that being part of that community and finding your roots there is a big part of being at least a primary care physician, and actually doing any kind of healthcare in a small community means that you're part of the community and you're connected to it. It's not for everybody, because not everybody wants to be in line at the grocery store and see the person you saw in the exam room, or have people come up and ask you stuff in the parking lot. So you have to have at least a tolerance for that. But I think the people that come out here and stay and like it do it because it's a calling. And I have said to students that I think you need some sort of a missionary complex to come and stay. And in some places, it is like being in the third world. But being in rural medicine really grounds you, and it really does help you see how everything's connected. So if you're a family physician like me, that really speaks to you. It gives meaning to what you do every day, and it really, I think that's the power of rural health. I guess that's the motto for today. One of the rural health conferences I went to, I remember somebody said when they asked, what are you doing here? The answer was, well, we're all here because we're not all there. And I think that actually, I think that's really true on a number of levels, but especially that we're here. And being here and being present, being connected, I think is the reason that I'm still doing this. So I don't know if there's any questions, but I don't have quite as much probably to say as the senator. But
do folks have any questions for Dr. Law? Want to pull any advice out of him now before you make that decision? Try to get an appointment with him? I don't hear any, Dr. Law. I thank you for your words of wisdom today, and again, I congratulate you for being one of our community stars, and we look forward to working with you in the future.
Thank you.
Thank you, sir. All right, we are coming up toward the end of the hour, and I know everybody has stuff to go, so I will wrap it up quickly. I want to thank everybody who's been here at all the various sites, and those of you that are calling in on your own computers as well. We will set some things up in the future, so stay tuned. If you didn't get questions asked that you'd like to, make sure you get them to me, and we will get them on to the senator from there. Please enjoy your National Rural Health Day, and don't forget, Bill has talked about all the money he has in his back pocket that he's dying to give to people. And Stacy Reed, Stacy, can you wave? Down in Klamath Falls. Stacy is our recruiter. Please, if you've got questions about looking for positions, make sure that you're contacting Stacy and working with her to determine what's best for you as you move forward and how you can get that ideal job. So that in the last minute, do folks have any questions that they want to ask? All right. Well, thanks, everybody. I greatly appreciate it. Have a great National Rural Health Day. Again, Dr. Law, thank you for joining us.